Assalamu alaikum warahmatullahi wabarakatuh, and a very good day to all of you. Firstly, I would like to thank the organizing committee, the president, Professor Malik, from the organizing committee, for the kind invitation to ask me to talk about autoimmune hepatitis, isolated and in overlap, team-based approach at the PFH today. We all know that AIH is an inflammatory disorder of the liver, occurs widely in adults and children, and it is a female preponderance diseases, and pathogenesis is really unknown. Of course, accumulations, evidence of genetic, environmental factors, and multifactorials involved in this disease. You can see here in the diagrams here where the AIH is predominantly hepatocytes and issues as opposed to PSC and primary biliary cholangitis, normal primary biliary cirrhosis, as opposed on the cholangiocyte issues, and the overlaps syndrome is in between the spectrum of the disease. If you look at the clinical features of autoimmune disease, liver disease, as you can see here, the AIH is more ANA positive, IgG, and interface hepatitis with plasma cell infiltration and predominantly elevation of the transaminase, as opposed to a primary biliary cholangitis with AMAs and cholangitis IgM predominant and overlap syndrome somewhat in between. These are the very congested slide. Apologize. Current concept of autoimmune hepatitis immunopathogenesis, where multi-step models involving the break of the self-tolerance in the hepatocyte autoantigens, and then initiate a lot of cascade immunological responses, then giving rise to progressive necroinflammation in the liver, as well as resulting in the fibrosis of the liver. And these cascades are involving many cytokine, chemokine growth factor that drive the process of immunological response, in particular in the autoimmune disease that we are discussing today. So essentially, AIH is characterized by three important features: elevations of aminotransaminases, hypergammaglobulinemia, and of course, pathologically interface hepatitis. It is an acute relapsing disease, untreated AIHs, exhibit a vaccine and varying causes, and of course, spontaneous recovery or progression to cirrhosis or acute exacerbation with acute liver failure. If you look at the presentation of AIH, acute presentation and jaundice happen 40% of the cases, and chronic presentation mostly in the elevation of liver biochemistry in 60% of the cases. If you look at the diagnostic scoring system, it's very simple. Look at the autoantibodies, ANA or ASMA, giving the points that you can see on the slide. Again, the IgG with upper limit of normal. And liver histopathology, this is the place that you get a really good pathologist to give the features that are compatible with diagnosis. And of course, absence of various virus, hepatitis A to E, and a lot of chronic liver disease, and the score 7 or more give definite diagnosis of AIH. These are the typical histological findings of interface hepatitis plus the dense infiltration of lymphoplasmacytic and preportal parenchyma invasion plus episthemal necrosis in patient with AIH. If you look at the types of AIH, the type 1, which is mostly that we see in practice, all age group, as I said early on, more in female, characteristic by autoantibodies of ANA, SMA, and 25% of anti-SLA antibodies, and variable presentations, either jaundice of acute or abnormal liver biochemistry, and the response to treatment is really good. As opposed to type 2, more on the young adolescent or children, again, more common in female with also anti-liver kidney microsome or anti-liver cytosol antibody, and these tend to be more severe and tend to be non-responder to treatment and relapse with stopping, and usually need a long-term maintenance therapy. Again, this is a representative of type 1 and type 2 AIH. You can see here mostly in adults that we see in type 1, and adolescent and children in type 2 AIH. Again, with the laboratory features of autoantibodies, as you can see, when I see ANA, SMA, predominantly in the type 1, as opposed to anti-LKM and anti-LC1 antibody, predominantly type 2. And again, there could be coexistent a lot of autoimmune related disease, such as type 1 diabetes, vitiligo, rheumatoid disease, and IBD, and so on. A remission after drug withdrawal is possible, but for the type 2 is quite rare, usually need a long-term immunosuppressive therapy. Again, these are showing the slide in terms of serum immunoreactivities and target antigen in AIH. You can see here, AIH present everywhere from the ANA and various forms of autoantibody, make it the diagnosis sometimes can be challenging. The score for the AIH, as you can see here, combinations of biomarkers, autoantibodies, and very important experience pathologists to tell us about the compatibility of the histological features with typical and non-typical AIH and absence of many chronic liver disease. As I said to you early on, 7 or more a definite diagnosis of AIH. The presence of, as I mentioned you early on, interface hepatitis, this hepatic rosette, and a lot of plasma infiltration, kind of cardinal features incompatible with AIH. And again, some cases has atypical histological features, but for other diagnoses. Bear in mind, the MUFL and NAFL is increasing widely everywhere in the world, and the ANA and SMA can be found in the biopsy-proven MUFL, in this case 51 over 225 patients, 23%, where different titers and positive autoantibodies are significantly associated with higher fibrosis stage and also grade of the inflammation. But before the biopsy, you can see here a majority has probable definite AI score, but post-biopsy, only small patients fulfill the diagnostic criteria for AIH in the setting of patient with MUFL or NAFL. These are typical infiltration cell interface of lymphoplasma in the case of autoimmune hepatitis. And also bear in mind, there are concurrent autoimmune diseases in patients with AIH. You can see over here, concurrent autoimmune diseases are pretty common in patients with AIH, and this can mirror the full range of known any form of autoimmune diseases, ranging from primary biliary cholangitis, PSC, thyroid disorders, vitiligo, rheumatoid arthritis, IBD, celiac, and the list goes on up to the sarcoidosis. They also very important to make a note that the ANA SMA can be found in biopsy-proven MUFL. You can see here positive autoantibodies, less likely to have to moderate to severe steatosis, but the lobular inflammation can have about up to 0.5% of the patients. Again, ballooning degeneration, advanced fibrosis were not different between these two groups. And we also bear in mind that flare of AIH causing acute and chronic liver failure, as you can see on this study here, part of my colleagues involved, advanced age and more severe liver disease, a MELD score of 27, and the presence of hepatic encephalopathy and fibrosis grade giving the unfavorable response to corticosteroid therapy in patients with AIH. These are the baseline approach of suspected patient with AIH, where you get a patient suspected autoimmune hepatitis, you work up all the standard of autoantibody screen, and of course, one of the important one to do liver biopsy, have a good liver pathologist, very important to recognize interface hepatitis and many other features leading to diagnosis of AIH and treat accordingly. And of course, some other aspect like fatty liver and bile duct injury, giving rise to other diagnoses, including overlap syndrome, is very, very important in the workout of the patient with suspected AIH. If you look at this after diagnosis, of course, the steroid plus with or without azothioprine, the mainstay treatment for therapy. Of the 20% of the patient who did not respond, only 9% are the true non-responders. Those are mostly non-compliance to medication. As you can see here, those who are response in about within a month or so after the diagnosis, they can continue to have maintenance therapy with such as azothioprine. But for those who are not responding, as I said to you early on, we have to review the diagnosis, maybe other features that intervene, and maybe replacing azothioprine with different immunosuppressive agents such as mycophenolate, as well as probably need a low dose or TAC or tacrolimus, and also can consider a biological agent or further form of therapy if the patient failed to respond. Again, the patient with AIH, you can see here those AIH overlap with PBC. We treat predominantly syndrome, and either if AIH and PSC, we treat both simultaneously. Again, the steroid is the essential therapy based on the dose, using 1.5 to 2 milligram per kilogram, and then maintenance therapy, and again, attempt to withdraw the treatment by performing biopsy to look the disease in remission, and of course, observe the patient very, very closely. These are among the treatment algorithm, as you like, recently published last year in Hepatology. The first line treatment of steroid, nowadays the favor using the budesonide, which is 90% bypass the metabolism in the liver and give the left side effect using of the steroid. Ideally should check TPMT level, but again, it's not practical and expensive even to measure other markers. 6-TGN or 6-MMP also cost money to the patient. Patient with cirrhosis, again, the steroid, do not use budesonide. In this case, adult prednisolone, a dose of 20 to 40 milligram, and also azathioprine, again, check the labs within a month or so, and depends on the availability in the country, testing the improvement of the biomarkers. Patient acute severe AIH, steroid, again, we not to recommend to use budesonide or azathioprine. A patient dose up to 60 milligram per day, and then again, pretty quick to check the laboratory testing for the marker to see any improvement of the patients. And again, depends on the response of the patients and follow up regularly. Depends again on the availability of the patient coming to your clinic, and then to try to taper the steroid and give azathioprine as a maintenance therapy. And for those who acute severe AIH, probably we try to use the lowest immunosuppressive therapy to maintain the remission, and do not withdraw the immunosuppressive therapy for this group of patients. Now, the issues and management of AIH are many. Of course, there are many dual pathologies sometimes can be involved, NAFL, MAFL, and NASH. Steroid therapy, we all know the various side effects among this patient, and concomitant NAFL NASH may be worsening of the fatty liver and make diabetes worse. Management of other diseases, metabolic syndrome, weight, and optimally control diabetes, and sparing use of steroid is very important. Use immunomodulators is reasonable, and of course need to co-manage not only with our colleagues but also with dermatologists, diabetologists, rheumatologists. Those are using a lot of immunomodulators, including nephrology. Sometimes in Malaysia we got a lot of SLE coexistent with AIH, quite important in terms of co-management of the patient. These are the recent guidelines in terms of diagnosis and management of AIH, both in adults and in children. What's new since for the last 11 years or so? I think the diagnostic scoring system should be used only to support clinical judgment in challenging cases and to define AIH cohort for clinical studies. Immune checkpoint inhibitors is widely used in many other specialties, oncology and hematology, and has been associated with immune-mediated liver injury and frequently steroid responsive, but the liver injury lacks autoantibodies and typical histological features of AIH, something that we need to recognize. Histological features of NAFL can represent up to a third of adult patients with AIH, and concurrent presence of NAFL or MAFL may influence the response to the therapy. And of course, we all use widely now FibroScan to assess the stages of hepatic progressive non-invasively. Now, testing of the thiopurine transferase enzyme prior to giving azathioprine may not be practical in the low resource setting. I personally do not do that, maybe not much relevance in our setting. And budesonide is the one that we're using a lot nowadays to prevent the side effect of the steroid. And of course, azathioprine as a first-line AIH treatments in children and adults who do not have liver cirrhosis. Azathioprine can be continued even throughout pregnancy, whereas the use of mycophenolate is contraindicated, we all know, in pregnancy. A liver tissue examination prior to drug withdrawal in individual with more than 2 years of biochemical in remission is preferred, but it's not mandatory for in adults, but required in children. And what's also new from this guideline compared to about 11 years ago, mycophenolate or tacrolimus can be used as a second-line treatment in children and adults of AIH who have failed to respond to the first-line therapy. Patients with acute severe AIH should receive prednisolone and followed by liver transplant if no improvement within 2 weeks. whereas patients with EIH and acute liver failure should be evaluated directly for liver transplant. And of course, glucocorticoid can be discontinued after liver transplant, and we can continue to monitor the patient for recurrence EIH. Again, depends on the availability of liver transplant, whether we should send this patient for early assessment or not. With that, thank you so much for attention. I love to interact with all of you physically, and hopefully next year we can meet in person for the meeting. Thank you for your attention and have a good day.